Hello, I'm Christina Davis, Director of the Program on U.S.-Japan Relations. Good evening to those of you joining us in Boston, and good morning to those of you joining us in Japan. I welcome you to join us for the seminar, Rethinking Japan's Response to the COVID-19 Pandemic. Here in the United States, we envy Japan for having held back the devastation of COVID-19, with about 18,000 deaths compared to 700,000 in the United States. Japan had moderate restrictions of business activities, and despite a slow rollout, has now achieved very high vaccination rates. Yet despite the reality where we are envious of the response in Japan, many in Japan are quite critical. Indeed, Prime Minister Suga ended his term as Prime Minister after only 1 year, in large part as a response to the criticism of the government for not having had an adequate COVID-19 policy. So we would like to step back and look at where the Japanese government has done well and why there were some problems and areas that could be improved. And in order to understand this full picture of Japan's response to the COVID-19 pandemic, we are really very fortunate to have a leading expert joining us tonight. It is my pleasure to introduce a leader in the field of international public health, Dr. Kenji Shibuya. His training includes both a medical degree from the University of Tokyo and a doctorate in international health economics from Harvard University. Currently, he is serving as the director of Soma COVID Vaccination Medical Center in Soma City, Fukushima. Before these positions, he served as professor at King's College London, professor and chair of the Department of Global Health at the University of Tokyo, and is a well-known and distinguished scholar of health policy and economics, who has expertise in demography, statistics, epidemiology, and has published many articles in top medical journals that are highly cited in the field. He's contributed to an influential effort to estimate the global burden of disease in a comprehensive cross-national study. As a policy leader, Dr. Shibuya has advised the Japanese government spearheading its strategic direction for global health policy. He has recently served as the special advisor to the Director General of the World Health Organization and as a member of the Scientific Advisory for the Coalition of Epidemic Preparedness and Innovations, a pandemic vaccine fund that has been investing in COVID-19 vaccines. With this track record of incredible contribution to the academy and global public health, Dr. Shibuya is a very busy person, and we are so grateful that he would share his time to talk with us tonight. The seminar is part of a special series of the Japanese Economic Statecraft, and it is co-sponsored by the Takemi Program in International Health of the Harvard T.H. Chan School of Public Health. Before we begin our talk today, I'd like to share with you the event we'll be hosting next week on Manners to Rules, Legalistic Turn in Governance, Secondhand Smoke Prevention in Japan and South Korea, featuring Celeste Arrington, who is a professor at George Washington University. And I'd like to remind you, we ask you to keep your microphone muted during the presentation. After 30 minutes presentation, we will invite questions from the audience, where you may either raise your hand, a virtual hand, as a participant button, or you may write a question in the chat. We ask you to respect privacy and not record the event. Without any further ado, I'd like to turn to our speaker. Thank you so much, Dr. Shibuya.
Thanks, Christina, for such a wonderful introduction, and I really appreciate the organizer for this opportunity. So let me share my slide. Okay, so I'm going to talk about Japanese response to the COVID-19 pandemic. Because I'm not a governmental official, and I've been critical of the response because, yeah, of course, as Christina mentioned, compared to the US or the UK, the number of casualties, death tolls, much lower in Japan. But compared to other Asian Pacific countries, Japan's performance is not that great because we have neighbors like China, New Zealand, South Korea, Taiwan, which have a great track record to suppress the transmission and minimize the damage, yet maintaining the economic activity. But things, as you know, the things have been changing so rapidly in terms of COVID almost every day. So I like to give you some of the specific issues related to the Japanese model to tackle COVID. So I skipped my self-introduction, but currently I'm working in Fukushima area to help the mass vaccination program. Previously, I was a bunch of housekeeping staff in global health. One of them was to advise Tedros, who is under attack sometimes, but he's a great guy. And also I was involved in the creation of the vaccine fund, which is called CEPI, which was the first entity to invest in Oxford vector vaccine and Moderna's messenger RNA vaccine. And it was created at the time of the Fukushima summit in 2016. It was a great spin out of the Abe administration as well. So personally, I'm a big fan of all things inspiring, elegant, and differentiated, and over to this is just my personal opinion. So this is the response ranked by Australian Rowing Institute earlier this year, and Japan, UK, and the United States are not ranked well, but things have been changed, particularly from the earlier phase of this year. The major difference is obviously we have more knowledge about science, particularly availability of very effective vaccines, and also some of the measures to control. So, many countries are shifting from suppression or even elimination, as in the case of New Zealand, to manage and control the COVID. Something like the flu. Of course, not the same as flu, but we are shifting through the vaccination and living with COVID. So that's where we are now. But these three countries, which I know well, are not necessarily doing well. It's not because they are not scientifically equipped, but mostly political, social, and even cultural factors may play a role. So I'm going to talk because I have only half an hour. So I focus on just three things. One is because many of you know how to prevent infection, but I would like to go back to basics to control infection. And also with relating to the first point, what are the major issues in the Japan model? So particularly as a Japanese expert, and even Abe administration at the time, the Prime Minister Abe, even Prime Minister Suga, very, very proud of so-called Japan model last year. But we are paying the price because we are kind of we are complacent and kind of self-congratulatory, because my point is that it was primarily driven by people's voluntary effort rather than government intervention, scientific intervention, including testing, vaccination, or health service provision. So I focus on two issues. And finally, I will touch upon some briefly on the future direction in terms of how to improve the Japanese COVID response. So first, three basic approaches. So any infectious disease, I think there are only three ways to prevent infection. One is disrupt the route of transmission. So wearing mask, ventilation, hand washing, social distancing. The extreme example is lockdown. Just shut down the city so that disrupt the route of transmission. Second is because everybody is not infected, so it's not efficient to behave as if everybody were infected. So it's important. Secondly, it's important to identify and remove the source of infection. So therefore, early detection and isolation of those who are infected, particularly in the case of COVID, as you know, asymptomatic transmission plays a very important role. So that's exactly the reason why we should focus more on the mass testing. And finally, inclusive host immunity through vaccination. So In the case of Japan, particularly from the beginning, Japan has been focusing on disruption of the route of transmission and asking people to behave properly rather than providing testing. And I just showed the example and delay the vaccination process. So primary focus, too much focus on the first strategy approach in the case of Japan. So this is the interview of the three major experts on the governmental committee. Omi is the chair of the governmental subcommittee. Omi is currently is like Tony Fauci in the case of the United States. So he always appeared with the prime minister in the press conference. So Omi is leading this entity. Wakita is the head of the National Institute of Infectious Disease, and he's also the chair of the advisory board for the Ministry of Health. Oshitani is a scientist, a professor of infectious disease at Tohoku University, who is spearheading the scientific, technical part of this strategy. So in this interview, Professor Oshitani said, Wuhan, the China city where the COVID started, and they are not aware of the gravity of novel COVID, and people, they might think that it was easy to control at first because there are a few serious patients. It was not necessarily correct because right after this, there was a Lancet article saying that it's getting there and it's very severe. And so at the time, I think they downplayed, underestimate themselves, the Chinese position as well, kind of sarcastic. So, and also he said, lockdown is 19th century strategy. So therefore, there is an alternative approach to control infections through behavioral changes among the general public. That's what it said. And that was a major way of thinking behind their strategy, focusing on disruption and transmission through people's behavior change. So when I saw this, wait a minute, in the public health, we know behavior change are really difficult to do, right? So it's easy to say, oh, you need to change the behavior, but that's the least things we could achieve in the most of the cases. So that's why there are a bunch of series to tackle behavior change. But in this case, particularly tackling unknown, potentially very fatal, transmissible new virus, how could we change people's behavior without knowing what kind of virus we are dealing with? So after 1.5 years, now Dr. Ami is saying we need lockdown registration. So because we have a big wave at the time of the Olympics, but now it's gone after 2 months. And the Suga administration imposed a state of emergency declaration, which is a mild lockdown. It's a kind of voluntary people's restriction of the movement. It's not a draconian lockdown as implemented in the US or in Europe, but it's a kind of lockdown, mild lockdown. And because at the time of Olympics, as you can imagine, people didn't listen and didn't follow the state of emergency because people are so fed up. And the government was asking people, oh, you should stay at home, watch TV, and behave properly. On the other, we have to celebrate the Olympics. So they sent a very mixed message and people are really confused. So obviously, this kind of messaging and state of emergency didn't work. So he is now supporting lockdown, even though they say lockdown was a 19th century measure, and they are kind of sarcastically decrying that kind of route. So over the 1.5 years, I am very uncomfortable with this kind of scientific advice, because over the years, as you know, every day there are so many new insights, publication, new ideas, new experiment, new empirical data set. We see every day. And more or less, we know what kind of approaches to mitigate risk, and even the scientific and both scientific, medical, and public health measures. But now they are talking about we need register lockdown. At the time, the world is moving ahead to lift the restriction. So there's something wrong in that kind of way of thinking. So I turn to the issues about the Japan model. So as you know, as Christina mentioned at the beginning, last year particularly, the first and second wave in the Japanese case, we did very well because the number of deaths was minimal. The case is not that large, but this was, in my opinion, but also the independent investigation by the civil society. It was primarily driven by people's voluntary effort rather than governmental order or any scientific approaches. So I'll focus on three issues. One is testing. Probably some of you, particularly Japanese people, know that in Japan, testing was really restricted. Even now, the test is not necessarily available on the spot. The last year, when there was a public cry that tests should be done more aggressively, even Prime Minister Abe asked the Ministry of Health to increase the number of tests. It didn't happen. So question is, why is testing so restricted? Because one of the major approaches to prevent infection is identify the source of infection and kind of isolate them. Because not everybody is infected. It's very inefficient to behave as if everybody were infected. So, but that's exactly what Japan has been doing. So why was testing so restricted? So it stems from the professor. I'm not accusing him. That's one way of one approach. So the expert, they mean governmental expert, came up with the idea, so-called cluster control approach. Behind this, there are several logic behind this. One, not all infected people will pass on to the infection to others. So they assume 20% of infected people will infect the rest of the 80% will not pass on to others. 20% are super spreaders. So the usual 20-80 Pareto hypothesis, which may be true because if you look at dispersion of the transmission pattern, there should be some sort of that kind of dispersion in terms of transmission. But we don't know who will be the super spreader. It might depend on the person or it might depend on the environment. So to implement this approach, he emphasized that we should focus on the cluster of relatively severe cases. I mean, those who have pneumonia for a couple of days. It's very severe, right? Not severe in terms of clinical, but in terms of daily life, they think that those who have a relatively severe condition, like early sign of pneumonia with high temperature, we should focus on these patients and trace the cross contact. Then the cluster, if we prevent the spread of this cluster, then the transmission will go away. That's their fundamental hypothesis. But COVID, the major route of transmission is asymptomatic transmission. So without testing, how could you prevent that? So in the NHK interview, he said, Japan is managing the current transmission by restricting access to PCR testing. I was very shocked by hearing that because testing is essential to identify the source of transmission. But this is still haunting response to COVID. So the global consensus is that fundamental problem of the COVID is asymptomatic and airborne transmission, right? Not necessarily direct contact. But still, government is not officially saying that airborne transmission is the major route of infection. And on top of that, the expert in the government committee started Instagram, SNS, and some sort of blogs, and they are saying that if you have a symptom, stay at home and stay home for 4 days. And if the fever doesn't go away, come test at the health center. But again, we know that the major transmission occurs right before the symptom start to show, just before, and then after 3 days, the potential for infection will go. And also, they have been very, very negative about the negative proof of testing from them. And this is still haunting because there are quite a few people who stay at home and stay there for 4 days, even though they have a fever, a really high fever, and they will pass on the transmission to the household members. So why this happened? So, we have a national debate. I'm very shocked that even this scientifically simple issue was debated every day on TV show, newspaper, among science committee. Seriously, I have never seen that kind of discussion about testing. And then Dr. Ami, the chair, went on to say, we should classify into 3 cases. Symptomatic cases, of course, we should test because we are implementing cluster control approach. Second category is asymptomatic cases with a high probability of infection, like hospital setting, nursing care setting. We should do it. But thirdly, asymptomatic cases with a low probability of infection. It's a potential community infection. So they say, we don't do testing for the third part of it. But without tackling the third part of it, asymptomatic cases with low prior probability of infection, like school setting, even workplace, we cannot stop transmission. So they are completely mixing up the issues about clinical diagnosis and control of transmission, or even maintaining the social activities. So when I spoke out early March last year, we should aim to give testing to all the people in Japan. These government officials said, "Oh, Kenji is mad. Kenji went to the UK and he turned out to be a crazy guy, so we should just ignore him." That kind of negative campaign was done, and every day I have a heated debate on TV or media. But what the ministry did was using, it's Japanese, but basically, in essence, they used very strange assumption on the PCR testing. So they used specificity of 99%. But those who know PCR testing, the false positive is virtually zero if you do the quality control. So this assumption is just scientific fraud. But they use this information and saying if we test many people, we have many false positive cases, more than the real infected cases. And they lobbied in the Nagatacho, the policymakers, last May, when there was a chance to boost the number of testing. So this is one of the error. It's sad because the government spread infodemic in terms of testing, and still they are trying to do it. So I asked the Japan Medical Association president, Dr. Yoko Kura, to set up independent task force because I can't trust the governmental expert on this. So he set up independent task force on PCR testing, and we came up with the conclusion that testing should be done regardless of prior probabilities to control infection and maintain socioeconomic activity. And we also said that PCR testing is a social infrastructure to manage COVID. So, but still, ministry was mixing up the accuracy of PCR and its quality control issue, and mixing up clinical diagnosis, meaning testing whether there is a virus in your body versus whether there's infectiousness in your saliva or not. So they completely mixed up the clinical diagnosis and infection control matter. And finally, they ignore the importance of asymptomatic and airborne transmission. And currently, there will be a general election, and Prime Minister right now, Kishida, said we are going to give PCR testing free for everyone who wants to do that. But now the ministry is trying to, delete the term PCR, and they are trying to downplay the testing for free, and they just changed the term to testing will be available at the pharmacy or something. So they are trying to downplay. So at this stage, even the Prime Minister promised to the general public, I don't know why they stick with this scientific fraud approach on testing. So if you look at data from our data staff, the Japanese testing is stagnant, very, very low. The UK, Singapore, as you know, they lift the restriction, and one of the strategy is to massively expand the testing. In Singapore, the number of cases are skyrocketing now, but I spoke with the government advisor there. They are not worried because 80% of the cases are asymptomatic cases. And this is because they gave all the rapid antigen tests at home, at workplace. So it is primarily driven by the increased number of cases to detect asymptomatic cases. So they are not so worried about it. So second issue is about the vaccination. So one of the good things about Prime Minister Suga was I really admire him in terms, because I'm helping Fukushima in terms of mass vaccination. And what Prime Minister Suga and Minister Kono did well was vaccination. So the motivation behind that was to hold the Olympics. So at the time of the Olympics, the vaccine coverage in Japan, fully vaccinated, is around 25%. It's very low. But if they could have started and March or at the latest, then I personally think that we could have Olympics in a safe and secure manner with audience. So right now, Japan, exceeded United States and also UK, ramping up very quickly. So which is great, but initially it was delayed. We could have started around February when the US started the vaccination as well. So why the vaccination delayed? Because if we could have started a few months earlier, we are in a very good position to manage COVID even from now, and even hold the Olympics in a more safer manner with audience. So there are possible reasons behind the delayed rollout. One is historical. So there has been a series of lawsuits in the 1980s and 1990s, particularly adverse event, which made policymakers very, very risk-averse. Japanese vaccination history is a history of lawsuits because we don't have, non-failure compensation system. So there's always the lawsuits between victims and government. So bureaucrats are so fed up with this kind of legislation, history of legislation, so they are always very risk-averse. So they impose a so-called bridging trial with a very small number of Japanese patients, even for this Pfizer, Moderna, AZ vaccination, which have been tested with so many people. So that really delayed more than 3 months. There's no scientific basis for this. Even just testing 200 Japanese patients, we can't have a convincing safety or efficacy result. But this is just a process, but government imposed this bridging trial, even at the national security, at the time of national crisis. Second is structure. It's a structures thing. And so in 2016, I was an advisor to Health Minister Shiozaki, and there was a scandal on the vaccine industry. And we wrote recommendation paper to the minister and saying that Japan's vaccine industry was heavily subsidized and seriously uncompetitive on the global scale, and public awareness about vaccine safety was low, notably HPV vaccination still. And we said, we warned that Japan will face a serious risk if a pandemic breaks out. And it happened because they didn't do anything after this recommendation. Not at all, actually. The final political. So Japan's relative success in handling the pandemic early last year, primarily by people's effort. So they are kind of complacent. Or we did it. Japan did it without draconian measures, without testing, without vaccination. Japan is great. Japan is exceptional. And that kind of mindset might have played a role. So this is summary of our task force recommendation in terms of vaccine and blood products. There was a scandal of one company, Kaketsken, one of the subsidiary of the government ministry, and they screwed up some of the data set. So the ministry wanted to set up their own committee and just punish this company. But the minister Shiozaki, he's an expert of governance. He has been working on governance for a long period of time. Thought that it's not issue of a single company. It is a systematic problem in the Japanese industry. So he asked me and Dr. Omi and two others to help them to come up with the recommendations. So we identified the key issues, more than that, but basically there is a lack of consideration of vaccination as a national security matter. And there was a lack of mid to long-term national strategy on vaccination, partly confounded by the history of lawsuit. And also the industry is highly protected and subsidized, lacking scale and global competitiveness, something like the financial sector in the 1990s. So we advised that the government should employ evidence-based vaccine policies, and we need to transform Japanese vaccine industry and the market in a modernized way to enhance competitiveness and global scale. And harmonize global regulatory process. You shouldn't stick with the Japanese specific bridging testing clinical trials, which doesn't have any scientific value. And finally, we advise we should contribute to global health. So we help the creation of CEPI, as I said earlier, from this report. But fundamentally, we warn the government we need to develop domestic capacity to produce pandemic vaccines and vaccine of public health relevance by enhancing strategic global partnership. Because we have so many small to medium scale farmers, but it's important to consolidate using partnership with global big giant, and also investing in ventures and new companies, new technologies. It was time to do that, but the government didn't act. So that's why we are here right now. And finally, I have only 5 or 6 minutes to go. So the other thing is, why Japanese health system is so fragile? You may have heard that in the last big wave around August, there were more than 250 patients died at home without access to hospital bed. It's shocking. In the US, it could happen, but these days in Japan, where universal health coverage was the national pride, easy access, no gatekeeping. So I was very shocked here in Japan, a person who didn't have a chance to get treated when they, at the time of COVID. It was really shocking to me, but why it did happen? So in your left-hand side, on upper bar chart, COVID patient, compared to other US or UK, France, it's much lower. But you have to be very careful when comparing the cases per population or deaths per population because the number of testing is different. So it's an underestimate, obviously, but relatively small. In terms of number of hospital beds per 1,000, Japan has probably largest number of hospital beds per person. And ICU bed, not that much, but not that bad compared to the UK or Italy. Number of physicians, okay. Number of nurses, not that bad. So we have so many hospital beds. Why? There are people dying at home without access to hospital bed. So on your right-hand side, so problem is the majority of Japanese hospitals are small to medium scale private hospitals. And also let me just, so this is the shocking news that 23% of patients are left at home. And the government announced that because we don't have a hospital bed, we may have to leave the patient at home. So I'm very worried that that will not work out. So what government should have done was to secure the number of hospital beds as many as possible, but they didn't do, and eventually it happened. It was quite shocking to me. Here in Japan, a country with universal health coverage, easy access, one of the best health systems, people died at home when they need support. So it's actually COVID revealed, as in many countries, the fundamentals of pre-existing system failure. So before moving to the UK, I was the chair of the governmental committee working on physician work style. It's a very strange term, work style reform. But that was one of the major political agenda of the Abe administration. So actually, physician work style reform is not setting the upper limit of working hours. It is more on the focusing on making the things enhance the productivity and enhance the value added of the health system. But at that time, what we found out were very low productive, high volume, yet low value added services. So probably differentiating fragmented services, mostly small to medium-sized private facilities, and more than 155 hours overtime per month at the university hospitals, limited number of GPs who can look at a whole body, and excess patient demand because lack of gatekeeping function. So we knew the fundamental structure problem when COVID started, and we expected, because the COVID problem is the exponential growth of cases followed by the hospitalization. So last year we discussed. I was in the discussion with Minister Shiozaki, and he was the chair of the governmental governance committee, and we came up the proposal to fix this problem. And he wrote up the proposal and saying we should depart from the ancient system to infection, which was built 120 years ago. So the LDP ruling party, recommended to strengthen national government command system and flexible, effective initial response and integrate public health and medical care. We are totally disrupted between public health and medical care compared to other countries. And revamp information system, reform National Infectious Disease Institute, and border control. The major issue here is for the government to ask the hospital, not the private hospital, but both private and public hospital, but primary public hospital to secure beds for the COVID patient. And also, forget about the binary public health center, and medical system. It should be totally linked. So, but surprisingly, public hospital not accepting COVID patient. If you look at on your right-hand side table, these are major public hospitals: National Hospital Organization, Japan Community Hospital Organization. See, the proportion of beds allocated to COVID patients is just too small. For example, JCO, Japan Community Hospital Organization, nationwide, only 5% of their beds are allocated to COVID patient, and 42 of them were actually used. So meaning only 3% or so, or 2% of their beds are actually used for the COVID patient. Jacob, the president, is Dr. Owen. So I didn't criticize, but I asked the press, media, and also policymakers, this is not right. Their mission is to provide the best available care for the people at the time of the crisis. It is written in the mission. So I asked the press to ask the question to policymakers at the Diet Parliament. And now the Prime Minister Kishida is asking these folks to open up the beds, but it was too late. So I finished this. So Shiozaki said it's a national disaster due to incompetent policymakers. So he is stepping down and pass on to his son for this election. He is retiring. So he said, I regret that we couldn't change the infectious disease law, and the ministry continues to ignore our proposal from the ruling party. And he was the only person who opposed to the proposal to leave mild patients at home, which suggests the deteriorated policymaking process. And policymakers do not respect experts and use them for their own objectives. Experts are also not necessarily competent. So harsh, but I personally agree with him on that front. So future direction, just quickly, so there was an independent investigation committee. It's a civil society committee. They look at the last year's Japanese response. So they said it was a strategy that relied on people's voluntary effort. And I think we should shift from zero COVID to manage COVID through vaccination, oral antivirals, which will be available soon, and testing and securing hospital bed. We know what we should do because we have science, we have scientific knowledge, we have experience over the 1.5 years. But still, in the case of Japan, except vaccination, things are really stagnant. So I'm very worried about the next big wave. So this is the data from Institute of Health Metrics and Evaluation about Japan. This is the estimate. So we repeat the state of emergency every 2 months. And usually the wave is the wise of the wave is 2 months. Strangely, according to New York Times, it's a 2-month cycle theory. It's a mixture of seasonality and people's movement and vaccination efficacy, and also unknown viral characteristics, in my opinion. So if you take it into account the seasonality, we expect the increase in the cases from November, very soon. But Japan opened up lifted the state of emergency, and people were hanging around, drinking alcohol started. It's okay for now, but it's a time for them to ramp up vaccination and aim at 80% of coverage. And on top of that, we need massively expanded testing and also occasion for the school to open up through ventilation, mask, and use regular testing. So to summarize, Japan model was primarily relying on people's voluntary effort. People did it very well, but people are already fed up and no longer following governmental state of emergency integration, no wonder. So Japan model was also not necessarily scientifically valid, but kind of anecdotal and political, reflecting the pre-existing governance system failure. And I think it is essential to shift from people's voluntary effort to scientific and precision public health, personalized approach to manage COVID. So this is my final slide. So I talked a lot, sorry, but it is the excerpt from the Fukushima report by Kiyoshi Kurokawa. In his preface, he wrote, "Its fundamental causes of this Fukushima accident to be found in the ingrained conventions of Japanese culture, our reflexive obedience, our reluctance to question authority, our devotion to sticking with the problem, status quo, our groupthink, and our insularity." And also, he's going on to say that it's a collective mindset of Japanese bureaucracy and they continue to put the organization interest ahead of the paramount duty to protect public safety, notably in the case of the COVID testing. So unfortunately, we repeat the same mistake, but I think this is, I hope that we should learn lessons from this and move ahead. After this election, I hope the things will be slightly changed. So I'll stop here. Thank you so much.
Thank you so much for a fascinating presentation. Certainly, no one will accuse you of being reluctant to question authority or insular. You've given a very convincing discussion about the challenges that were faced on testing, allocation of hospital beds, and a call for the government to bring in more science in its guidance for ranging to deal with the pandemic. I know there's quite a few questions in the audience, and so I'm going to turn to the audience now for questions. And I ask everyone to keep their questions brief so that we have time to get in several people. I'm going to start off first with our associate from the program on US-Japan relations, Nobuhiro Mitsuoka, who's a project manager at NTT doing research at Harvard this year on sustainability.
Thank you very much for your informative presentation. I was very impressed with your objective and constructive advice. My question is, what should Japan do now to implement a scientific approach in future pandemics? If you have any advice, I'd appreciate it.
Thank you. That's a very interesting and a fundamental question. It's not about the people, it's about the governance. Particularly, if you look back what happened in the Fukushima, I think it was an issue about so-called electronic village. And now it is the issue about infectious expert village. So people in this field are kind of secluded. And in the case of Japanese advice, in a specific area, there's only one single voice, from particular bureaucrats and backed up by specific scientists. It is extremely important to have a basic scientific idea that to agree to disagree, right? So we need to have a scientific debate, independent view, governmental view, and we discuss and come up with a consensus. That's what we do every day in all the academic environment. Eventually, we need to agree on something. But in the case of a Japanese expert committee, they are not allowed to agree to disagree. And most of the scenario will be written by the bureaucrat, predetermined. So that's a problem.
Next, we can hear from one of the bureaucrats who's spending time with us at Harvard this year. Yuki Yamanaka is Deputy Director at the Ministry of Economy, Trade, and Industry, and he would like to ask you a question.
Thank you very much for your interesting lecture. I feel your statement mostly political, social, cultural factors. My question is about the structural issue. What are your policy suggestions for reforming the healthcare structure? Given the structural problem, you mentioned poorly funded small to medium-sized facilities and so on.
Yeah, in the case of health provision, all doctors, minister bureaucrats, even meaty bureaucrats whom I know, everyone knows that the problem is structural, and we expected this could have happened. And COVID has revealed the fundamental system failure in the healthcare provision system. So basically, it is a system, it's a financing system to pay for the service, status quo. So there is no incentive for anybody to change it. So finance is set to keep this kind of status quo. So, for example, in the case of work style reform, not all doctors are working over 155 over time work. Relatively skewed number of people, particularly young doctors working at the university hospital, emergency care, are working day and night, more than 200 hours per month overnight overwork. But majority of doctors working at the GP and some of the small hospitals, they are not. So as you say, too many small to medium-sized hospitals are a source of inefficiency, but also political power with the Japanese Medical Association consisting of GPs are also problematic because they are the biggest supporter of LDP. And so there is no incentive for the LDP policymakers to support and help these young doctors who are working 200 hours over time per month at the hospital. So it's a structural, but it's also political, and there is no incentive for anyone in the power to change the system. But now, people, general public, now understands something is wrong with this Japanese medical system, because you or me might die at home without access to the hospital. It's shocking. And you cannot simply point a finger to the head of medical association. It is structure, and even the ministry, they didn't do much, not ministry in this committee, but the Ministry of Health. They knew this problem. And they knew Shiozaki and the LDP sent a recommendation to them to change the infectious disease law so that the ministry and the minister have a word to the public hospital to open up the word beds quickly, but they resisted. So they really wanted to stick with the status quo, and they don't have any incentive to change it unless there is a strong voice from the public. So it's very difficult. We know the system, we know the problem for a long period of time, and we expect it, and it happened, but still very reluctant for them to change it. Sorry, I'm not answering directly, but it's a big issue.
I'm going to take two questions together quickly. Richard Perry and then Keiko Kawabe.
Hello, thank you very much, and thanks for your presentation. It's very interesting what you say about the low levels of testing, and I wonder if you could tell us why you think testing was suppressed to the extent it was. If it's so obvious scientifically that there's benefit in it, what was the motive behind it? Was there a genuine misunderstanding of the benefits of testing, or do you think there was a hidden motive? I mean, some people say that they just didn't want people to know how high the infection rates were. Is it as simple as that, or is there something else behind it? And then a second very quick question.
We really don't have time for two questions. I want to let Keiko Kawabe ask her question.
So quickly, I think it's a mixture. So they still think at the beginning, the chief medical officer thinks that, I don't know who lectured him, but he believed that PCR testing will lead to high false positive number, which is not true, but he believed in it. But secondly, it was true that health center capacity for PCR testing was very limited. But I checked, but we have so many private laboratory, and health center is, as you know, it's overwhelmed. So many staff and very, very low resources. But outside health center, we have a private facility, private laboratory, and the universities, research institute. We do have so many laboratories which can do PCR testing. But government want to stick with their system. So here's the ministry, National Institute of Infectious Disease, and these umbrella, there are a bunch of public health centers, and they would like to use that. And this is the infectious disease law to do active epidemic surveillance. So they use that system. They stick with that system. It was established 120 years ago without using available private facilities, university, institutional laboratories. So there are two things. The chief medical officer and other medical bureaucrat, didn't understand the value of PCR. If it's intentional, it's a crime. But I think unintentionally they believe that PCR testing was not so accurate. Secondly, the capacity issue on their health centers. But I checked the capacity outside health center. It was enough at the time, almost twice or three times much. So it was a kind of excuse to me.
Thank you. Keiko, would you like to go ahead with your question?
Thanks, Christina. Thank you, Dr. Shibuya, for your very interesting talk. As I'm sure you're aware, in August, the Tokyo Medical Association announced a plan to try to better support patients who are recovering from COVID-19 at home, which included a recommendation for prescribing ivermectin for mild cases. Do you think that this will be helpful at all in the next wave, or is the key to saving lives obtaining more hospital beds?
Yeah, so there seems to be a debate about use of ivermectin, and the Tokyo Metropolitan Medical Association president, Dr. Ozaki, believes that ivermectin will be useful. But given the current scientific knowledge about it and the current recommendation from the scientific community, I don't think the ivermectin will be a good solution. Instead, I think, as I said, it's important to enhance the number of testing, vaccination, secure the beds, and also we need to approve the oral antivirals very quickly once it's approved. So of course we need to carefully look at the implication of ivermectin from different clinical trials, but at this stage, I don't think the ivermectin will be the solution.
Thank you very much. Thank you very much.
Kosuke Imai.
Thanks for interesting talk. So I wanted to ask a quick question about whether Japan was successful in terms of implementing data-driven public health policy in the case.
You know much better than I do. That's why you moved to the US, no? No, I would say it was one of the fundamental failure because, for example, modeling the trajectory projections of infection. I think in the US, in 10, 15, so many different models, and come up with a consensus about the trajectory of the disease. And finally, it's a political decision which one to employ. But here, we only have one model at the governmental level. And when I asked about the code and the data behind that, they never shared. Because I just want to, I didn't want to criticize, but I just want to play with that, with my own approach. So, similar to the first question, the fundamental problem of the Japanese scientific community, particularly government advisor, is they stick with one view. And from the bureaucracy standpoint, they don't want to change it, even though they know that things are changing. If you know more scientific knowledge, for example, they denied at the beginning asymptomatic transmission and also airborne transmission. But of course, nobody knows at the beginning that this is the disease with asymptomatic transmission through airborne route. But now it's definite. But still, they don't want to change the strategy on the basis of scientific knowledge. They stick with the initial cluster control approach still. So it's not just the availability of data, but I think it's about the governance, independence of the scientific committee. Because in the case of US, you are lucky to have a Tony Fauci, but also, scientific community, academic discipline, they speak out. And they have a huge debate. That will shape the consensus. But here, public health society, medical community, except Japan Medical Association Independent Task Force, nobody spoke out because once they spoke out, they are very afraid that the Ministry of Health will not fund them, something like that. So data-driven strategy is absolutely we need to harness, and that is lacking. And also, as I said, fundamental problem of the Japanese system is total disruption between public health and medical care. So if you have a symptom and you get tested, it turns out to be positive, and then whether you will stay at home or get medical care, it was decided by the health center, not doctor. And then if you get serious, which hospital you'll be admitted, it will be decided by the health center. It's totally efficient. It's a medical care from testing to intensive care unit. And the data are completely separated. So there is no way this positive patient will receive this treatment at which place and what will the prognosis outcome. We don't know. That's a problem. So that's why the Shiozaki committee last year to fix it. But the ministry didn't buy it. So that's a problem.
Well, if you can keep pushing, hopefully they will improve their ability to have.
We're pushing. We're asking Prime Minister Kishida and their colleagues to fix it. So they're racing a little bit, but you never know.
We're almost to the end of our time, so I want to just ask one last person to give their question. Professor Yves Tiberghien from University of British Columbia, who has a book that just came out comparing the government response in East Asia to COVID across several governments. If you could just ask a brief question to close our session, Yves.
Yeah, thank you so much, Christina, and thank you, Shibuya Sensei. Great to hear your presentation. So I'll just have a very quick question for now. There's this group in the US that has done a new data set on Japanese deaths from COVID. It's IHME, the IHME.
Yeah, Chris Murray was my PhD advisor. I know him very well.
Oh, good. Well, and so they came up with death numbers based on, the unexplained death that in the spring and in June, July this year came to be 10 times higher than the official reported Johns Hopkins data. What do you think of this? Is there any truth to it? I know the gap has closed now in that data, but how do you evaluate that data set?
Yeah, so you mean the gap between reported and estimated, right?
Right. Yeah. The estimate.
And obviously, reported data grossly underestimated because the testing is not done, and that's why they are going to use excess mortality approach by cause, which we are trying to work with them. So, yeah, it's obvious everywhere there is a huge gap between reported versus estimated deaths. Partly because the testing capacity, partly because of misclassification, partly because the unknown excess mortality stuff. So we have to be very careful about the implication of estimated deaths. But I'm a big fan of IHME, and also I'm asking the government to do this kind of exercise, but they are not doing it. So I'm now planning to do it by myself.
Great, thank you.
Thank you very much. I hope you have good luck in your efforts to gather better data to persuade Prime Minister Kishida to listen to you. And I was especially encouraged as a scholar of international relations to hear you call out for better global regulation and approval of vaccines. There would be so much more harmonization possible so that countries could have a joint rollout.
Absolutely. Yeah, regulatory process, particularly for least developed regions and supporting them will be very, very essential to tackle COVID. Yeah.
Yes, well, thank you so very much. We really appreciate your sharing your expertise, and we have many here listening, and we hope more will listen to your advice. Thank you.
Yeah, thanks. Thanks for such a great interaction. Really appreciate it. Thank you. Good night.
Good night. Thank you all.